Hello, welcome to our first responder peer support team training. My name is Mike Wynn and I'll be your presenter for our time today. Today we're going to be talking about the utility and some of the usefulness of first responder peer support teams, but more particularly we're going to be talking about some of the ethical dilemmas or ethical challenges that you as a new peer supporter might confront when you're providing peer support to your colleagues. And then we're going to wrap up with a ethical decision-making model that we hope you'll find is a useful decision-making tool when you should encounter one of these in your practice. I need to point out to you before we get started that this presentation is a portfolio project for a course that I'm taking at Colorado State University Global in the Psychology 515 program, Ethics in Practice, and then my instructor is Dr. Susie Johnson. So let's get started. First, we need to recognize that first responders may be first on scenes that are difficult, dangerous, and challenging. Not only can first responders face risks to their physical safety and well-being, but by virtue of their duties, they are also the first to provide assistance and emotional support to both victims and survivors. As a result of this, first responders are exposed to a higher degree of trauma than many people in the general population. As a result of this increased trauma exposure, first responders also are at increased risk of certain behavioral or mental health conditions. Some of these conditions may include anxiety, depression, post-traumatic stress disorder or PTSD, increased rates of substance abuse and or substance use, and increased rates of suicidality. So not only do our first responders face an increased risk of negative mental health or adverse mental health consequences, but they also report that they're often adverse or averse to seeking or accepting mental health counseling. And there's a couple reasons for that. Many first responders report that they either have lack of access to mental health treatment in their agencies or their jurisdictions, or sometimes they report that they just don't know how to access those mental health services. Many first responders also report that they have a fear of appearing weak or damaged to their colleagues or to their supervisors. They don't want them to think that there's something wrong with them. First responders also report that they have concerns about the confidentiality of information that they share with mental health services that are provided by their employers, since in many cases the employers are the client and they believe that anything they share with the clinician may be reported back to their agency. Many first responders have legitimate concerns about negative career impacts, that if they report that there's something wrong with them, they may be put on limited duty or assigned to the desk or taken off the road. First responders also report that they simply don't believe that non-responder therapists or clinicians will understand what they've seen and what they've done and the experiences that they've been through. And finally, and perhaps most importantly, many first responders report that there is still a significant stigma associated with admitting that there may be something wrong and asking for help in order to make yourself healthy again. We should point out that there are certain protective factors that being associated with a first responder or public safety organization do provide. In principle, among those factors is social support. Most uniformed first responder agencies have a culture of cooperation and teamwork. They value mission accomplishment, and they place the good of the team above themselves. This strong culture of social support can be a protective factor against many of the mental illnesses or mental conditions we discussed earlier, and it can help mitigate those effects if it's taken advantage of and leveraged properly. One of the proven ways to take advantage of social support within a first responder organization and provide assistance to our fellow first responders is the establishment of peer support teams. So one of the questions that people ask is why peer support? And one of the best answers I found to this question is provided by Dr. Jack Digliani. He's a clinician and a peer support specialist out of Colorado, and he actually wrote several manuals to assist with providing peer support. This is why Dr. Digliani indicates that peer support is important. And I'm not going to read that to you. You can read it. But essentially what it says is that peer support fills a gap that cannot be provided by department psychologists or department-sponsored employee assistance programs. And I want you to pay particular attention down there to the last couple of sentences. The difference, the power of the peer. The power of the peer is the factor that is constant in the support provided by peer support team members. It is the factor that is not present in other support modalities. Basically, what that's saying is that your peers are always there. And if you know that there's always going to be someone there for you, then you're probably more inclined to take advantage of that resource. So what are some of the specific benefits of peer support? Well, peer support provides direct support for the department members and their families. Now, the EAP may also provide support for families, but that's not always a guarantee. Peer support is designed to be multifaceted. Peer support serves as a debriefing asset for the department members exposed to trauma or critical incidents. And peer support can also serve as a counseling resource within the department, separate from the employee assistance program. Now, those are the benefits of peer support and the advantages that it can provide to a department and to the department's members. But setting up a peer support team is not without some risk. So there is considerable risk with setting up a peer support team, and I should point out that some of that risk can be mitigated through training. All peer support team members should receive specialized training, and most of us should recognize that that training will not be equivalent to the formal education that is received by a social worker or a psychologist or psychiatrist. And critically important among that gap between training and education is formal education concerning ethics. If you're going to set up a successful peer support team, it is critical that peer support team members be trained in and committed to adhering to high ethical standards. Nothing will damage a peer support team faster than peer support team members who are engaging in unethical conduct. So peer support fills a unique niche within a department's wellness program or wellness initiatives. And because it is in this unique niche, peer support team members may become aware of sensitive information about their colleagues. The first ethical challenge that peer support team members may confront is issues surrounding privacy. The APA, or the American Psychological Association, have written guidelines that require minimal privacy intrusions by all therapists. And this is true for all written and verbal reports. Any information regarding a client should only be conveyed if it's absolutely necessary and pertinent to the matter at hand. Stemming off of privacy and related to privacy are concerns over confidentiality. Now, depending on what jurisdiction you're practicing in and what agency you're supporting, confidentiality can vary across the country. Confidentiality is particularly tricky for peer supporters because, well, some aspects of what a peer support provider may discuss with a client can be held confidential. Some are absolutely not. And it really does vary from jurisdiction to jurisdiction and state by state. So for example, in Massachusetts, here where I am, Chapter 329 of the Sessions Acts of 2018 does provide for some confidentiality protections for some certified peer supporters. If a member of a peer support team is certified through either the Massachusetts or the National Associations of Peer Support, they are granted the confidentiality status of a licensed clinician, and information that is conveyed to them in their role as a peer supporter is held in strict confidence. But even information that is provided to them in their role as a peer supporter may be subject to some exemptions. So what are some of those exemptions? Well, confidentiality does not protect information that a client provides about the conduct of crimes, criminal conduct. It doesn't protect information that may concern the abuse of a child or the abuse of an elder or any other member of a protected class. And it doesn't protect information about direct threats of imminent harm to the client or to someone else. All of that information may, and in many cases, must be divulged. There's other limits to confidentiality. Depending on a department's policies and procedures, some information divulged to a peer supporter may not be held in confidence. every member of the peer support team needs to be aware of what those policies and procedures state. And we all should be aware that state guarantees of confidentiality are not recognized in the federal courts. In addition to privacy and confidentiality, another ethical issue that may be faced by peer supporters are boundary issues. Now, peer supporters may work closely with the people that they are treating or working with as their clients, counseling as their clients, not treating. And if you're a peer supporter providing peer support to your own agency, you may be on the same shift, in the same unit, work out of the same station, house, or precinct as the people who are approaching you for peer support. And clearly, you're already going to have established relationships with these people. And these interactions can vary widely from day to day, and people may approach you in a variety of capacities. And you need to be clear about where the boundaries are and what capacity they're approaching you in. Is my colleague coming to me and coming to complain about the call they were just on, a day-to-day interaction that we would consider to be routine just between fellow police officers? Okay, that's not an official peer support capacity. But are they coming to me and asking me, because they know I'm a member of a peer support team, to sit down with them for some one-on-one support sessions? Well, now I'm in a different role and we have a set of different boundaries. Or am I providing a team debrief with my entire peer support team to an entire operational unit that was just involved in a critical incident? Every one of these things is going to present a different set and series of boundary challenges. Pivoting off of boundaries, we now come to the ethical dilemma that is presented by dual or multiple roles. This is going to be critically important for peer supporters because we are all going to have multiple roles with the people that we are providing peer support with. We're going to be colleagues, we may be supervisors, we may be subordinates, we may be within the same unit, we may be on the same team. So we have to be cautious about entering multiple roles with a colleague that we are already engaged in peer support. We're already going to have at least a dual relationship because we're in the same organization, unless we're providing peer support outside of our organization. Now we're going to have a relationship based on peer support. We need to be very, very cautious about establishing another relationship outside of what's been already established. So let me give you an example. If I'm providing one-on-one services to a colleague, a member of my department, and that colleague is involved in a critical incident for which the peer support team, is now going to be activated to provide the debriefing, I may want to think twice and consider recusing myself from that debriefing if my client is going to be one of the officers to be debriefed. If I were to participate in the debriefing, I would have added yet another dual relationship on top of the ones that we already had. Are there any questions? That's a little tricky. Okay, let's move on. These are all important, but this one is perhaps the most important, particularly because people who are not involved in peer support may not understand the distinctions of peer support. Peer supporters need to be very clear and aware of their abilities and the services that they can and cannot provide. Peer support is support. It may rise to the level of some type of informal counseling, but it is not therapy and it is not treatment. Peer supporters should always be aware of the limits of their competency and the limits of the skills that they can provide and the situations that they're qualified and prepared and equipped to deal with. Peer supporters should always contact their clinical supervisor when a case exceeds their competence. And peer supporters should feel comfortable making appropriate referrals when necessary. So, I've had some specialized training, but this is a little outside of my area of competence. I think you need to talk to our clinical supervisor, or maybe you need to talk to one of the clinicians from the co-responder program. Peer supporters should not attempt to provide services they're not qualified to provide beyond their ability or competency. So those are some of the ethical dilemmas that a peer supporter may find themselves in while they are now trying to provide support to their colleagues. Should you find yourself in a dilemma like that, what are you supposed to do? Well, ethical dilemmas can be tricky and they can be complicated. And in our studies of peer support, one of the things that has been suggested is that a useful tool for working through these ethical dilemmas is an ethical decision-making model. Now, there's a bunch of ethical decision-making models out there. And I can't tell you that, any one is better than any other one. But what I can tell you is that through the ones that we looked at during my studies, I came up with a simple ethical decision making model that I think would be useful, particularly for members of a peer support team, without getting into the weeds of somebody who's providing a higher level of clinical counseling. So let's work through some of the steps that you might want to consider in an ethical decision making model as a member of your peer support team. So this is the model we proposed. It has 12 steps, and those 12 steps can be done in chronological order, but this is designed as a cyclical model because once you reassess, you may find yourself right back at the top, re-identifying a different version of a subsequent problem, and you can just keep working the model around the wheel until you resolve this thing entirely. So we're going to start at the top, and we're going to work through each of these 12 steps one by one. And, if I were to find myself in a dual relationship or a confidentiality or a privacy dilemma, what might I do to resolve the situation? So number one is identify. We want to state the question or dilemma clearly and succinctly. What exactly am I dealing with here? What is the ethical dilemma I'm facing? I want to define and identify that challenge and very quickly state make that statement as clearly as possible. And then I want to ask some questions. What are the underlying causes that led to this dilemma or this ethical challenge? Could any of these been anticipated or avoided? What did I miss? Is there anything that's going on outside of the scope of what I already know that I may not be aware of? Is there an underlying motive? Is there an underlying motivation? If I think that's the case, where can I get some additional information? This is also a question of perspective. How might the client view this differently? Do they see this as an ethical violation or a breach? And as I go through this identification process, identifying and defining, when possible, I want to place this statement in writing so that I can utilize it in later steps. Once I've identified and defined the problem, I want to do a little self-analysis, and I want to determine what is my emotional or instinctive reaction. What's my emotional response to being informed of this ethical dilemma? Am I angry? Does this tick me off? Am I a little miffed that my friend and my colleague who came to me for help is now bringing me this other problem on top of the problem he brought me originally? And once I start to ask myself those questions, I want to take a step back and detach and ask, is my judgment being clouded by my personal feelings? If I were in this person's shoes, would I be as upset? Would I be as angry? Would I be as concerned about what they're reporting to me? And if the answer to that is yes, maybe my personal judgment, maybe my ego is getting in the way, and I need to take a deep breath, step back, and take a look at what's really happening here. One of the things that I want to ask as a member of a peer support team is this a boundary or multiple relationship issue? Is this something that I allowed to be created because I have a working relationship with this person, I want to help my brother or sister out, and I stepped into a dual role that I probably should have avoided because if it's predictable, it's preventable, and I saw something coming. If that's the case, maybe I want to ask myself, do I want to recuse myself? Do I want to step back from this? Go to my clinical supervisor, ask them to intervene, and see if they can tap me out? Once I've gone through this step and I've determined what my emotional state is, what my emotional reaction is, I want to move on to the next step. This is a little self-reflection and a little self-examination. Look back at my initial response and ask myself, does my initial reaction have any biases, blind spots, or cultural incongruities? Do I have a conscious or unconscious bias at work here? Do I have prior experience with this colleague that's causing me to manifest prejudices? Did I work patrol with this officer? Maybe I have some concerns about their work ethic. They're coming to me and I'm treating them maybe as not the high performing officer that I would treat a little bit differently. I'd give a little more care and consideration to. If that's the case, that's on me. and I have to take ownership of that. Once I go through that self-reflection process, then I'm going to take a little time and I'm going to review the case up to this point. If this is an existing case, I'm going to go through all the prior documentation. I'm going to ask myself, did we obtain proper written informed consent? Did I brief the client at the outset of the therapeutic relationship on any limits to confidentiality? Is there anything in the case file from either prior contacts that I had with this client or maybe somebody else from the peer support team had that would indicate or predict this current situation? Have they entered into a peer support relationship with somebody and brought ethical concerns in the past? That might inform and give me some information about what's going on here in the current situation. Once I've reviewed the case file, my next step is going to be to consult all of the applicable professional and department and organizational standards. I'm going to look at the APA standards, principles, or APA ethical principles and standards. I'm going to look at the IACP's peer support guidelines. I'm going to look at our department's policies and procedures that are in place regarding peer support. And I'm going to look at the team standard operating procedures that are in place to see if any of those documents can provide me with any guidance and give me any idea as to the next steps that I might have to take. As I'm going through this process, I'm going to locate the relevant sections of any of those foundation guiding documents, and I'm going to note them in my case report that started with my problem statement. After I've gone through the applicable professional documentation, I'm then going to turn and make sure that I've reviewed all of the relevant statutes that may apply in my state or my jurisdiction. Is there any relevant legislation? And what does that legislation state? Does the dilemma I'm facing today fit within the framework provided by the law? Was the situation that I'm being accused of breaking confidentiality on something that I was required to because it was an imminent threat of harm to the client or someone else, or they admitted criminal activity, or they engaged in conversation about abusive behavior to a protected person? Well, the law is very clear in cases like that. I'm going to ask myself, am I as a peer supporter or a member of the peer support team, are we operating within or outside of a status of protected privilege or confidentiality? Once I've done all my homework, now I'm going to go find my clinical supervisor and seek clinical supervision. I'm going to provide my supervisor with my problem statement, my self-assessment about my biases and my blind spots, my case review, and all of my findings from my review of the pertinent ethical standards and guidelines, policies and procedures in the law. I'm going to discuss with my clinical supervisor my initial reaction, my reassessment of my initial reaction, and any changes to my approach that I may have taken onto myself as a result of the work that we've done up until this point. While I'm meeting with my clinical supervisor, I'm going to ask and determine if it might be appropriate at this point to discuss the ethical dilemma or situation with the client. If the clinical supervisor and I agree that there isn't going to be any harm to the client if we approach them about this situation, and it won't necessarily harm the therapeutic relationship any more than it's already been done, and in the interest of everybody's self-interest and protection, the supervisor is willing to sit in on the meeting with me, then it may be worthwhile to try to resolve this situation informally by sitting down with the client and trying to mediate an outcome. Once I've met with my clinical supervisor and discussed whether or not it's appropriate to have an intervention with the client, then I'm going to determine my next course of action. What is the appropriate thing to do here? What's the best action going forward? Have we considered alternative solutions? Have we brainstormed on this for a while, noodled it around, kind of tossed the ball back and forth and come up with the best possible solution? Have we considered alternative perspectives? What's this going to look like from the point of view of the client? What's this going to look like from the point of view of the command staff? What's this going to look like from the point of view of outside agencies looking in? What are the possible consequences of my determined course of action? And If there are potential consequences, what steps can I take proactively to mitigate them? Having done all of this, the next thing I'm going to do is make sure that I documented this entire process from identifying and defining the problem all the way up through the determination of the appropriate course of action on the same document that started with my problem statement. I'm going to document the entire ethical decision-making process, including the discussion points with my clinical supervisor. And once I've thoroughly documented everything, including the determination and the decision we made for what we're going to do going forward, I'm going to include those documents in the case file relative to the client that brought the dilemma forward. You still with me so far? This is a lot. It's only been 10 steps. So now we're almost there. The next step, we're going to implement this solution. We're going to take the decision that we came up with and we're going to put it in place. And we're going to do that proactively, and we're going to take those steps to carry this decision through. We're not going to let this matter linger. It may have been out there for a while already. It may have taken the client a little while to get their courage up to bring this dilemma to us to begin with. It took us a little while to get through those first initial steps and to meet with our clinical supervisor. Now we've decided we need to do something. We're going to act decisively to resolve the situation quickly and effectively, and hopefully put this matter to rest. Now, no good plan survives first contact. So even though we've implemented the plan, it's a good plan. We have high hopes for this plan. We have to have a contingency plan. And so once we implement the plan, we're going to reassess the plan. We're going to continue to monitor and evaluate the plan. We're going to ask ourselves, is this plan working as we intended it? Is it effective? Is it resolving the situation that we're attempting to solve by our problem statement? And if they can't answer all of those questions affirmatively, we're going to modify the plan. Now we started at the top with identify, and we've worked our way all the way back up to the top. We're going to reassess. And if at this point we have to change the plan and redocument the plan, we are now back at re-identifying, and we're going to start to work the plan again until we come up with an effective solution. Everybody with me so far? Great. Okay, so we've talked about the value of peer support. We've talked about some of the risks associated with peer support. We've talked about some of the ethical dilemmas you can find yourself confronting if you are serving as a peer supporter. And we've discussed a 12-point ethical decision-making model that we can use as a tool should we find ourselves, unfortunately, in one of those situations. We're almost done. So let's just recap. Peer support is a valuable resource for first responder organizations. Some research will indicate it is the most valuable resource that a first responder organization can have in place as part of their emergency services, wellness, and resiliency programs. But as we've discussed during our time today, this establishment of a peer support program is not without risk. First responders who also serve as peer supporters are going to be confronted with considerable ethical challenges. Having an ethical decision-making model in place beforehand can assist you as a peer supporter in working through ethical dilemmas professionally and efficiently. This is not something that you want to try to fake your way through or fake it till you make it, because these ethical dilemmas have significant consequences. So having a tool in place to use is going to put you in a much better position. And as I said before I introduced this 12-point model, there are many ethical decision-making models out there. I can't speak to the value of all of them. I can't speak badly of any of them. Some of them are more complicated than this one. Some of them are more simple than this one. Just have one. Don't go through this alone. All right. I want to wrap up with a quote. This was something I grabbed from. So if you're not familiar, Lexipol. Lexipol is a very, very prominent policy development training organization for first responders, police, fire, and corrections in the United States. And Lexipol did a asynchronous webinar. It's not dated, but not in the too distant past, about the value of peer support in first responder organizations, particularly police organizations. And in that Lexipol webinar, they had a quote It's a quote from one of my favorite law enforcement trainers, public safety trainers. It's Lieutenant Colonel Dave Grossman. He is the author of On Combat and On Killing. And Colonel Grossman's quote is this: "Joy shared is joy multiplied. Pain shared is pain divided. You're only as sick as your secrets." Colonel Grossman tells this quote, or uses this quote in his book, when he talks about the differences between the experiences of our veterans who returned from World War I and World War II by ship, where they spent weeks and sometimes months with their colleagues talking about their experiences and debriefing those experiences until when they got home, they had treated themselves and normalized some of those horrific experiences, as opposed to our veterans from Vietnam who flew home on a Freedom Bird. 16 hours later, were back in the country, in the United States, with no connection with their colleagues and no one to talk to. And the mental health implications were staggering. Joy shared is joy multiplied. Celebrate your victories. Pain shared is pain divided. Debrief your fellow first responders. You're only as sick as your secrets. Don't do it. Don't keep this stuff to yourself. Thank you for your time and attention. If you have any questions, please feel free to reach out for me. And be safe, be healthy, keep the faith, do good work. Thank you.